Not in office. He is not in office. So let me make sure he's got us.
I'm here.
There we are, audio and video. Fantastic.
I've been here.
All right, good deal. Good deal. I told him you were traveling and in another meeting, so we are going to go ahead and jump in.
I was. Let me hook up to the other power supply so that we don't get kicked out.
All right. Fantastic. Well, we are back together. It's good to see names that we've seen in the past. So welcome and thank you for joining us after a little over a month. You know, it's a small group. We may make this a fireside chat if if we want to have an exchange of questions. We would love to do that. Of course, there's a lot to cover today, as you see, and I won't do formal intros. You all have been with us before, so we can skip that part. The agenda that you see here, a lot has changed, a lot hasn't. So what we're going to do is we're going to update the numbers. We're going to talk about the variants. We're going to talk about just vaccinations across the US and across the world. And then we'll tell you what's going on at Triumph. And so I want to make this something that is valuable to you all who are taking the time to do it, especially since we haven't been together for a month. And so I'll look for questions, as always, in the chat, or come off mute if you are on the phone by hitting *6. And I think knowing all the content we want to get through, it's going to be a quick 30 minutes. So Dr. Owen, that is your cue.
All right, we have a lot to talk about. Let's do the first part, the easiest part. I think everybody's pretty well aware. I mean, how many times have we seen these crazy slides of all of these variants and the new reported cases and so forth? But I mean, what an encouraging curve of the reported cases. I mean, this is what we've been hoping for a long period of time. And you can see that we did have that bump of a quote third wave that was in April, end of March through about the middle of April. And we've come down in number of newly reported cases substantially. Hospitalizations, if you see below that, numbers of testings being done, hospitalized patients have come down, deaths have come down significantly. That's what we've been hoping for all along. But notice one thing, it's not gone. And not that it ever will be 100% gone, but we still have a good ways to go. And we don't want to develop any mutations and variants that render these vaccines and our current immunity ineffective. So let's move on to the next slide. Top left, COVID weekly deaths, tremendously improved, right? As high as over 25,000 deaths per day in the United States, now down in the less than 2.5, 2.5 thousand deaths. So pretty big deal, very, very helpful. Let me move this just a second. I gotta move, let's see, there we go. To move this box is getting in the way of things. Percentage change in COVID deaths from December to May in various racial groups on the left and ages on the top. And you can see, I mean, it's affecting everybody about the same amount. There's a little bit difference in the Caucasian community versus some of the less well-represented communities, but within 5%, that's a huge improvement over what we've seen in the past. The share of deaths, this is somewhat of a misleading slide. You can see that the share of total deaths for 75 and over has decreased significantly. But if that percentage goes down of total deaths, something else has to go up, which is the 50 to 74. And that's probably the group we would have anticipated, maybe 40 to 74, something in that range. But that's total deaths and the percentage of total deaths, which is a misnomer just because it's misleading, because the total number of deaths is dramatically down. Next slide. All right, how contagious are the variants? So you see the Wuhan virus just on a, compared, to the what they call the RO number, general level of contagion. The original virus in Wuhan versus, look at the bottom right, measles or mumps. So almost 5-fold difference. Now, the version that caused Europe's first wave, as I've told you before, that came out of Italy and so forth and came to the US, and that's a factor of 3. Then there's other that we've seen. We've seen a UK strain, we've seen a South African strain, we've seen an EEK strain out of Thailand, we've seen the double mutation variant out of India. Now we have Alpha and Delta strains. And this is the natural selection and progression of viruses. The ones that are more significant, more contagious are the ones that survive. These are mutations. So mutations always, the ones that survive are the ones that have the capability of survival. And one of those ways is to be more contagious, to be caught, and to then be able to multiply more and more and more. So the more contagious a virus is, the more successful it's going to be. The more deadly a virus is, the less long-term success a virus has. It might have a lot of short-term success if it's very contagious, but if it kills all of its hosts, it doesn't have anywhere to live in the future. So the penultimate great virus for survival is one that is highly contagious, but not as deadly. The Delta virus is significantly more contagious than the others we've seen, 2.5 times the original Wuhan, and at least 2 times the first European strain that we saw. Next slide. All right, the EUA approved vaccine news and updates, and I think everybody's well aware of, in general, thought process of what's going on the left portion of the slide. From the bottom up, you got the Johnson & Johnson vaccine, the Moderna, and Pfizer. And Pfizer had more doses out and available than Moderna. And then we saw that blip of Johnson & Johnson, and then they had problems with clotting. And their use dropped off dramatically. They're still being used here in the US and other places, but as a percentage, it could have been a lot better, but it's still somewhat helpful that it's a player. And now Moderna has already asked for ages 12 to 17 for the FDA under EUA certifications. And Pfizer has asked last month for children ages 12 to 15. So essentially, we're getting to the point that everybody's going to be available, Moderna and Pfizer be available to 12 years of age and up. And unfortunately, Johnson & Johnson continues to have problems with 60 million doses thrown out in their Baltimore facility. So hopefully they can get their act together. But you can see that the push is towards the younger and younger people. Now, the big question there is, and I got asked this actually by a patient today, should I have my child vaccinated? Well, it really depends on your perception and your stance on what you're trying to accomplish. If you're trying to accomplish lack of your child being injured from COVID-19, sure, it helps. But we also know that it's not as, quote, virulent or likely to kill in younger people. But remember, they are still the vector and capable of spreading to the others. So because they also are less likely to follow stringent guidelines of social distancing, wearing face masks, and so forth like that, they're more likely to spread it to friends. and then to others who might be more at risk. So we don't, ethically and morally, we all don't want our children to be the cause of other people and older folks catching things and dying and so forth. But what we do understand here is that these vaccines are going to be available for younger and younger children. Each family is going to have some decisions to make. If you're thinking on a community basis, you want everybody as many as possible to get vaccinated, including the children. If you're thinking about just your specific child, the likelihood of getting COVID and dying from it is low. It's not zero. There are other side effects we'll talk about later of these viruses and so forth. These are going to be personal decisions that every family is going to have to make. Next slide. Rate of vaccination in the US. On the left, we've got 63% of the population with at least one dose. The White House goal was 70% by July 4th. They're not going to meet that. If you look on the right side, United States, 63% overall, and estimated time to 70% current vaccine rate would be 1 month. So it won't be July 4th, but it'll be probably late July. Look at North Carolina, it's gonna be 5 months. We were step in step with the rest of the country on average, but we have fallen significantly behind in our ability to vaccinate. And so it's going to have its effect on places where there are less vaccinated people. It's going to affect them more because that means there's going to be more potential spread in those states. And it's just unfortunately the way it is. So Alabama, Mississippi have a low rate of vaccination, and they're going to have harder trouble getting rid of this virus in comparison to other states. And we're not doing that much better. Another 5 months for us, that's getting close to Thanksgiving to have 70% of the population vaccinated once. Next slide. Vaccination rates by continent. Now, who would have predicted this? The richer countries of North America and Europe are able to purchase vaccine and get their population vaccinated a lot faster than the poorest countries in Africa. Well, this is a huge issue. And what it means is that places that are not well vaccinated are going to have a lot more deaths associated and a lot more likely to develop mutations. And as a result, countries are going to have to make some decisions about where they're going to allow their citizens to travel. And right now, is Africa a real safe place to travel? Probably not. And especially if they have a tremendous amount of people with active COVID and they drive a mutation that suddenly renders our vaccines and immunity ineffective, and then we bring it back here into the United States, that's going to be problematic. But as you know, with our civil liberties weighing against what's right for the community, our civil liberties for the individual, we're constantly trying to create an appropriate balance that's right for the community and right for the individual. And that's going to be really hard to strike when the virus really doesn't care. And it's going to do what it's going to do. And, we are the variable, not the virus. It will create mutations. The question is just when, if it's high enough population still with COVID, when it's going to create a mutation that renders our current immunity ineffective. Next slide. Complex slide, public opinions on vaccination, top left. If you just go to the far right, those who would definitely not get vaccinated really hasn't changed much. It's between 13 and 15%. Those who would do it only if required, not really changed a whole lot either, but let's add those numbers together and you get somewhere between 20 and 24% of the population is only going to do it if they're required by law or their company or they're just not going to get it. But what has happened is that the wait and see group, and specifically the wait and see group, is the one that we're really targeting, and it's gone down from 39%, and then by May, it's now at 12%. That's really the targeted group right now. And if you look down below, the full FDA approval, if a full FDA approval occurred, would that push the needle? I think it would. A lot of my patients who say that they are not going to get the vaccines because they're afraid that this has happened too fast and it's they haven't seen enough data and they want to make sure that it's safe. And I think that's the wait and see group. And if this gets complete FDA certification and approval, I think that you'll see us far surpass 70%. We'll get pretty close to 75% of the population. The question is, how long is it going to take for the FDA to do its full approval process? To the right, more than a third of those in the wait and see plan to get the COVID-19 vaccine within 3 months. Others are still going to wait. But I think that the FDA giving full approval will help significantly. If you look at the bottom left again, other things that might push the needle, if they were offered $100 by the state government, if they were offered free transportation, ride share company and so forth, 12%. That's important because we're talking about a group of the patient population in the United States that doesn't have access to transportation, but could still be spreading this. And that's the group I would hit and go after first from a federal standpoint and bring it to them. Have free tickets to a sporting event. Yeah, I might have done that too when I was in my 20s. Let's go to the next slide. Side effects, myocarditis. First of all, what is myocarditis? Let's break the word down. Myo is muscle, card is heart, itis is inflammation. So inflammation of heart muscle, the contracting portion of the muscle, not the electrical portion, but the contracting portion of the muscle. You can get myocarditis and other inflammatory nerve conditions. Everybody's heard of Guillain-Barré, where you have an ascending nerve paralysis in 1 in a million people who get flu shot. We've seen some of those same type of reactions in the COVID-19 vaccines, but myocarditis is happening a little more frequently, and it's usually related to the immune process and the antibodies formed, and then what they call the complement portion of the immune system. And it gets into a lot of medical jargon and detail, but it's the other part other than the antibodies that are bringing other immune system factors involved for inflammation. And therefore you get this myocarditis. So if you look at top left, myocarditis, pericarditis. What is pericarditis? The pericardium is the sac around the heart. The pleura is the sac around the lungs. And so when you take a breath in and the pleura is inflamed, called pleurisy, then it hurts every time the lung scratches up against that lining. Same thing with the heart. When the heart, as it's filling and squeezing, if it rubs up against the pericardium, which is the sac around it, then it can cause significant pain. It's usually worse when lying back because the heart then falls back against the back pericardium, a lot of pain. When you sit forward, then the heart floats in the fluid around the heart and doesn't scratch up against the pericardium as much. When you lean forward, it now leans up against the front of the pericardium and it moves against it and scratches against it and causes more pain. So we always talk about it being in the sniff position for pericarditis. You sit up, get in the sniff position, the heart's hanging vertically, and that should be the most comfortable position. You lean way forward or you lie back, you should have significantly more pain, and it can be like a knife stabbing. It's quite intense for some people. So this myocarditis, pericarditis, and if you look at Pfizer, after one dose, After 2 doses, it's at least twice as more likely to occur, all right? But 573 out of millions and tens, hundreds of millions of doses. So it's pretty rare, but it's not zero. And it's something that we should all as physicians anticipate, because we know what vaccines do and the immune system reaction it creates and how it might affect the myocardium, pericardium, all of these various nerves, brain, so forth. We're well aware of this. So this is not an unexpected type of problem. We fully expect to see this type of thing with any type of vaccine. It's rare, but it can happen. Median age in the 20s and early 30s, but you can see the ranges 12 to 94. But the average age is going to be somewhere in the 20s and 30s. Median time to symptom onset. Some people 0 days, some people as long as 33 days. After dose 2, some people as long as 80 days. There's a male predominance. Probably at least 2 to 1, if not 3 to 1. And if you look over here, symptoms on to the right, chest pain, that knife-like chest pain, sometimes worse with taking in a breath. Shortness of breath can occur. Changes on your EKG, that's the ST or T wave changes. There are some very, what we call pathognomonic, meaning that it's almost certain by seeing an early EKG change that you will have pericarditis. And then elevated heart enzymes. It's called troponin. And so we're used to seeing a leakage of troponin into the bloodstream associated with heart attacks. But you can also get it from myocarditis, which is inflammation of the heart muscle as well. And then some abnormal echocardiographic imaging, so ultrasound tests of the heart, you might see some fluid around the heart, things of that nature primarily. Next slide. Vaccinations for minors. It varies in each state. Who wants to do it? 4 in 10 parents say their adolescent has already received a COVID-19 vaccine or reduce our right of way. It's going to be the same situation. And now parents have another variable to consider. Getting a vaccine yourself and putting yourself at risk is one thing. Putting your child potentially at risk when you're already concerned about the vaccine as a heightened level of concern. And you can see that the only if required and definitely not 34%, but in the adult population, we're getting the vaccine itself, it's more in the 20-25% range. And like I said, I have all kinds of patients asking me about their children and are they going to get the vaccine and so forth. Most of them realize it's really a community service and they're going to do it. We hope enough people do get vaccinated, and obviously we don't want to see any side effects, but there will be some. For the overall community, it makes sense. For the individual and the parent, they're going to have to make their own decision as to whether it makes sense for them. Now, there are, if you look in the bottom left, parental consent is required in the orange states. In the blue states, like North Carolina, providers may waive the parental consent for a minor. And green states like South Carolina, Alabama, Columbia, Rhode Island, Oregon, parental consent is not required for all minors. I'm sure there will be for some who are unable to make their own decisions, but you can see that we're getting into states' rights again about what's right in each state and who's controlling what and the thought process there. Next slide. Vaccination incentives from employers. So these companies have no current plans to mandate vaccines for their workers. Answer no or answer yes. So who's giving financial incentives? Amazon, Kroger, Target. Who's getting paid time off? Walmart, IBM, Target, Starbucks, United Health Group, PepsiCo, Wells Fargo. Who's vaccinating at the work site? Walmart, Amazon, Kroger, Target, CVS, Walgreens, right? You can see there are a couple of companies that are really all in. They're going to do anything and everything to keep their employees in the best position of health as possible, because they know, I mean, just A, it's good for the employee, B, it's good for the company. It's a win-win from that standpoint. And then when their employees are present and not sick from COVID, then of course, they have more people able to come in and serve more clients that way. So Tom Sasser, everyone should focus, we can go through that in a minute. Is there another slide? All right, testing and vaccinations at Tryon. So we closed our Dilworth testing clinic, and we temporarily closed our Matthews testing clinic because the volumes were so incredibly low, which is good. We have the ability to open up on the grounds of the same clinic in Matthews with a trailer, and we are putting that into action as we talk. Testing will also be done potentially at that same location, depending on the need, whether or not they need turnaround in one day or others, that will dictate where we send them and so forth. But if there are significant employer needs and such, we can certainly discuss those and create plans to do so for you at either a specific location or at your facilities. Any questions?
Dr. Owen, I do not see any other than Tom's. We got about 2 minutes.
All right, it says, should folks that have had and survived COVID be regarded similarly to folks that have been vaccinated as far as masks and social distancing go? The answer is generally yes. But remember, a lot of it also depends on how long do these antibodies last. So if somebody got COVID in March of last year, do they still have antibodies? Do they still have the same level of immunity? We don't know the answer to that yet, unless we're going to test all those people. That's why we have these studies still ongoing, because we need to see what those effects are. So if somebody caught COVID versus somebody else who received the vaccine, say on 1/1/21, then right now they should both have about the same level of immunity. So the answer would be yes. But if I was going to compare somebody who got vaccinated on 1/1/21, somebody who caught COVID last June, I'm not sure I could tell you that they have the same level of immunity unless we tested from a year ago that person and their immunity now. So that could be complex. Does Tryon medical officers require masks on all employees that have not been vaccinated and allow vaccinated employees to not wear a mask? So if you look at the CDC recommends still that medical offices, when you're in patient contact areas, that all people wear masks, whether you've been vaccinated or not. But if you're in non-patient areas, and those who have been vaccinated do not necessarily have to wear masks, but can choose to do so. Those who have not been vaccinated should wear a mask at all times on the medical campus. Any new info or writings worth sharing with folks reluctant to get a vaccination might convince them to do it? Not really. I think that the most important issue is the one that I brought up earlier. We're trying to get over 70% to create the herd immunity. If we got 75%, that'd even be better. The one population that is sitting on the fence and says that at least half of them are sitting on the fence about one issue, and that is the FDA getting full approval. They're concerned about how fast this vaccine is developed. And if we can get that solved, we'll soar past 70% rapidly. Get pretty close to 75% of the population vaccinated. The other thing is, and I did mention it, I should say this, is I really do think the federal government, state governments, and local governments need to take the vaccine to the population, the most underserved regions, and make that more easily obtainable. That's what the it's what the Johnson & Johnson vaccine was going to be so helpful for, and then it kind of petered out, obviously, when it had all of its other side effect issues.
So we got a great suggestion. National Association of Manufacturers has created a kit that may help you, Tom, addressing a lot of the concerns. And so, Dr. Owen, I know we're a minute or two over. This wrap up will be different than what we've done in the past, because you're really saying, here's what I'd like you to take away for the next month, because it'll be, late July before we're back together. So you can close us out with those thoughts.
Hopefully, we don't need to meet before a month from now. If we do, it is because we have either a mutation, or we have, a mutation that's really significant, or we have some new and great finding. So for that, I hope we do have to meet, but the other way, obviously would be more problematic. It's not yet time to let our guard down. And we all innately know who is or who isn't practicing appropriate type of preventative measures. And we can do the very best we can. Remember, there are plenty of people who have been vaccinated that have caught COVID since, and there are now trickling in reports of deaths from those infections, from those encounters. These vaccines are not 100% effective. Watch your travel during this summer and through the rest of 2021. And everybody just be careful. And if you have friends that want to talk to us about getting COVID vaccines, please forward them to us. We're happy to sit down and talk with people. And if any of the employers would like for us to come and do any more discussions or this particular talk here, we're happy to do that too.
Very good. And with that, we will end, and we'll bid everybody a good rest of your day. We'll be with you in a month. And if you have any questions, come to our website or email me. We'd be happy to answer them. Dr. Owen, thank you, everybody. Have a great rest of your day.
Thank you, everyone.